Good morning. We're going to get started. Sorry to deal with this. It's hot. We're going to be sending around a sign-in sheet. Please make sure you sign both of them, particularly the one that has your email. We need to make sure we can read that if you're needing your CEU. So. And then, so would you just tell me you can call? Okay. They're going to introduce themselves. So good morning.
Thank you so much. Hey, good morning, everybody.
Good morning.
My name is Annette Mendela. I am the Director for Clinical Ethics at UT Medical Center, and I'm joined here by some of my colleagues who are going to introduce themselves.
Hey guys, I'm Melissa McDonald. I'm the Nurse Manager for the Emergency Department at UT Medical Center.
And good morning, I'm Diana Goad, Manager of Case Management at UT Medical Center.
Melissa and Diana are some of the unsung heroes in healthcare. We always think about our amazing doctors and our amazing nurses, but we don't always recognize just how much care is being delivered by people who are not providing direct patient care, but who are making sure that patients get where they need, get what they need, and so on. So these two are truly some of the wonder women in healthcare. Let me ask, so who else do we have with us? This session is intended to be interactive, so let me ask, in our little short-term 1-hour community of this room, who else is here? Who's here, for example, from law enforcement? Several. Other people in healthcare? Nobody. We can tell them whatever we want. Social services? Okay, great. Other roles that I haven't mentioned.
The ombudsman.
Ombudsman, thank you, yeah. Others? APS, oh, thank you, yeah. Say TCAP. Conservators, yes, absolutely. Okay, all right. Well, again, we're hoping that this will be an interactive session. We're gonna, so if you have things to say or things to ask, make sure and just speak right up. And we'll hopefully have some good time at the end for discussion as well. And I'm a real believer in the driving power of stories. So I'm going to kick this off with a story. It's not a real patient, this is a composite patient, but this patient's story will be familiar to many of us. We're going to call her Ruthie. Ruthie was a 75-year-old lady who was admitted with a UTI and some encephalopathy, but otherwise ambulatory, healthy, doing okay. She'd been living with a brother and sister-in-law for several months, but when she got to our ED, she said that her sister-in-law had beat her up and locked her out of the house. We did not note, despite careful evaluation, we didn't note any injuries or anything that suggested that may have happened, but we also know that sometimes it doesn't present that way and that we need to make sure that we are protecting our patients as best we can. So we made sure to file an APS report so that other people can have eyes on the situation, people who are better able to evaluate than we. Brother and sister-in-law, for what it's worth, denied abuse, but said that she could not come back to the home, that she had been too disruptive, that they could not care for her any longer. Turned out she was divorced and had 3 children. We got in touch with one son. He said that she had lived with him at one time, but she was too difficult and he did not want to be involved in her care in any way. The other 2 adult children did not respond to our phone calls. So I'm going to pass the mic to Melissa for a second. From an emergency room perspective, what's on your radar about Ruthie? What's a worry to you?
So a couple of different things. How many of you guys have visited an ER in our community, say in the last year? Let's just go with a year. All right. How many recognize that emergency department overcrowding is a problem?
Yeah.
Way up here, right?
Yeah.
Okay. So let's think about our patients like Ruthie that come in that do not have what we would consider a safe discharge plan. We are obligated to provide a safe discharge plan for our patients, and we absolutely want to be able to do that. So in this case, it states that Ruthie had a UTI and some encephalopathy. Those are great reasons for admission. But not all of these patients present that way. Or if this is something that can be taken care of on an outpatient basis, we are not meeting a reason to admit this patient. Does everybody realize we have to have something other than a social admission to admit a patient? Yeah? So we're looking for that medical admission.
What do you mean by social? What is a social admission?
So, sorry, a social admission would be this patient is medically stable. There is no reason to admit this patient to the hospital medically speaking. They don't need IV antibiotics. They don't need any special procedures done. Anything that needs to be delivered to them could happen on an outpatient basis. So they do not have criteria for admission. So a social admission would be basically those patients that don't have a safe discharge plan. That would be considered a social admit. That is entirely too difficult to actually make happen. So what happens to these patients can be very unfortunate. They sit in my ER and they need to be there for hours to get things done, but more than likely it's days to get things done. So if you think about a treat and release patient that is going to come to the emergency department and get to go home today, they don't require admission, the goal is to have those patients in and out of our ER in less than 180 minutes. That's 3 hours. So if you think about a patient that is in a bed for 24 hours, how many patients could we not treat in that time? And that's what we are faced with when we have these types of patients that have no medical criteria for admission, but we know that they don't have a safe discharge plan. So those are the things that immediately come to mind when we have these patients, and of course, involving our APS partners, law enforcement, whoever we may need to identify what's really going on in the home. And many times it may be that they can't really evaluate until the patient gets back there, but I can't send them back there because it doesn't sound safe. So there's a lot of different things that kind of go into that.
Very good. So we did admit Ruthie, again, not a real patient, a composite patient, and in her workup she scored 12 out of 30 on, we call it the MOCA, the Montreal Cognitive Assessment. So just checking for cognitive issues. And that's a score that suggests that she's got enough cognitive impairment that we would not feel good about her navigating life alone in an unsupported living environment. She insisted, in fact she volunteered, that she did not have dementia and that she did not see any particular risk for being at home. And she thought that living at home would be something she was interested in. Independence was her absolute core value. Like so many of us, being independent and being able to do what she wanted when she wanted was something that was just very, very important to her. Lots of attempts were made to place her in a supportive community environment, utilizing every resource that we knew to reach out to, and Diana is a wizard at knowing where those resources are and how to find them. Could a supportive shelter work for her? Could choices with an apartment work for her? A community case manager, representative payee, any number of things that we could think of. But she did not want, she had a very specific part of East Tennessee she wanted to live in, and she was not willing to leave that area. And placement was not successful. Okay. What's on your mind with patients like Ruthie?
All right, so just to kind of echo Melissa, so this patient was admitted. She did not have any medical needs. If she was being treated, maybe she was on a pill for an antibiotic. So, and she was ambulatory, so she's in a room. She's walking from the bed to the bathroom to the chair. She's pretty insistent that she has places to go. So, she thought she could return to an apartment. So we had to do some investigative work and contact that apartment. So multiple phone calls were made. So this is a lot of resources. You've got physicians that are rounding on her. You've got the case managers that are trying to investigate her story. We have therapy working with her to see, does she qualify for nursing home placement? Well, she was doing better, in the room physically than, some staff members. So she was doing great. That was not going to be a likely option there. So when we followed up on her stories, they were not as she recalled. She was not able to go back to the apartment. She was not able to go back to the family that she thought that she could because of the bridges that she had talked. So during this stay, we're basically trying to feel her out. We're trying to see what resources are actual options. So we're really we're trying to learn her story. And then coming up with these resources. And then like Annette said that she was very specific to East Tennessee, actually to Knox County. So, we're very limited because Knox County is very overutilized. So some of the options that we had were outside, not far, but if it was not within that county, then she was not interested.
So after 21 days in the hospital, okay, it's a long time to be stuck in a hospital room. And as Diana was saying, really, we don't like people wandering around, walking the halls. It's a fall risk, right? Especially, she was ambulatory, but maybe not as steady on her feet to be walking unassisted. And 21 days is a long time with a lot of nurses telling you what to do, right? She had a cousin that agreed to take her in. So we find a place for everybody sooner or later, but 21 days is a long time. And 4 weeks later, she came back, right? Another UTI. This time she said her cousin had hit her and had starved her. Again, no injuries, no weight loss noted, but again, we don't know, right? We don't know if abuse is taking place or if this is something that feels very real but is more a product of the cognitive impairment. We don't know, and it's not something that we can assess for sure. So again, another APS report filed so that others can look into this. Her cousin also, again, denied any kind of abuse or neglect, but also said she's not welcome to return and did not want to be involved in her care in the future. After her encephalopathy cleared, we did another cognitive assessment, and now her score was lower than it had before, now 9 out of 30. So this is a step we don't like to take, but we felt that we had tried to place her in the least restrictive environment possible, but that did not work well for her, and so we did a petition for a conservator on hospital day 4. On hospital day 32, Ethra Guardianship, thank you for everything that you do, was appointed, and she was able to be placed in a skilled nursing facility. Noting that on her earlier admission, even if we had had a conservator, we couldn't have placed her in a skilled nursing facility because she was doing too well. There's this donut hole where, you want your folks to do as well as possible, but that drops certain kinds of resources out. And so, Diana, I'm just going to ask you, what are you thinking about that 38 days? Is that what we're seeing lately?
Yeah, I did say that's actually pretty quick. And I think we had mentioned this was probably a pre-COVID situation. Because after COVID, and then there was a cap for ETHRA, so they can only take a certain amount of patients, and so once they hit that max, they can't take any other patients. So then once we identify a patient that we think is appropriate, then we make a request, we make a referral, but they are able to review it when they can get to it because they're trying to juggle all of these patients. And then once that happens, they agree that the patient is appropriate, and then we have to start the legal proceedings. And so court date on these legal proceedings also can take a long time. Just to give an example, for a current patient, I believe we have a court date that is a 6-week time frame. So from the time that we request it to the time of the court date, I think is 6 weeks. So that's none of this pre-existing that we've talked about to even arrive at that decision. So all of that pre-work requires, you have to learn the patient's story. You have to make sure that we've exhausted all other attempts to place this patient in an appropriate setting. So there's a lot of back work that happens there, and then you have to start the legal proceedings, and then you're waiting on the court date, and then depending when that court date arrives, then whoever's appointed has to deal with the financial aspect. And I hate that I saw another presentation for banking and financials and things like that, but that can be super sticky and can take a long time. So that is just another layer of this process.
Another thing, just because Annette has pointed out the number of days that this patient stayed in the hospital, think about the community effects that actually has for this one patient staying in the hospital that many days. So her first visit was 21 days. Our average length of stay for an admitted patient is currently right about 5 days. So think about how many other patients we were not able to get into an admission room because that room was being taken care of for a social admit. And then again, on the second visit being 38 days. So what happens to those patients that need admission but can't get into a room because the inn is full? they stay in the ER. They're real uncomfortable on stretchers, by the way. If you've ever laid on a stretcher for 18 hours instead of in a hospital bed, it's much different. So then let's continue backing up that process. We can't get them into an admitted bed, so they are staying with us in the emergency department until we can. And we already talked about all of the patients that we would like to treat that we can't from the ER because that bed is full. So those patients are then sitting in the lobby. So we've gotten really good at providing lobby care, which is not what any of us want to do. But we've also seen when this happens, we have an uptick in our patients that check in that need care and they don't want to wait that long and they end up leaving without their treatment complete. And then there's a whole follow-up that has to happen with those patients because what if their labs came back abnormal? You got to get them back in there and you got to convince them. I'm sorry, I know that you were here for 6 hours and I'm so sorry, but it's in your best interest to come back. And UT is not the only hospital that faces this. It's every hospital across the nation. There's so much information about it, but especially here in Knoxville, just how we feel fundamentally underbedded, and this just kind of makes the process even harder.
So as we've said before, hospitals have an ethical and legal obligation to, number one, evaluate and treat patients who arrive on their property, and then to ensure that they're discharged into a safe environment. These are good cornerstones. We don't want them to change in any way. The legal obligation, and there'll be a quiz on this later. The legal obligation, of course, comes to evaluate and treat comes from EMTALA, the Emergency Medical Treatment and Active Labor Act. And then CMS requires us to discharge the patient to appropriate post-acute services providers and settings. That's the legal, but beyond the legal is just the ethical. It's just the right thing to do. Of course it is. But it's not always possible. Sometimes patients are absolutely willing to go to a safe environment, but for whatever reasons, and there's a lot of reasons, and we'll talk about them in a moment, resources are not available to get them to that safe environment. Sometimes they want to return to an unsafe environment, like our Ruby, who wanted to go to the apartment she thought she had, but no longer had. And then sometimes folks are unwilling to go to a place that others feel would be safe for them, and so they don't want to leave the hospital, and so they refuse to participate in the discharge process, even though we feel like we could get them someplace that would be good for them. And so they stay with us because we can't actually get them to a safe place. So people can stay in the hospital for long stretches, weeks, sometimes months, sometimes several months, sometimes many months, with no need for being in the hospital, but also no safe discharge plan. So they used to call this granny dumping. There's actually a small literature in my literature, in the bioethics literature, called granny dumping. And it was referred to elders who were left in emergency rooms by their families, and the families drive off and are never seen or heard from again. But for a variety of reasons, it's no longer just granny and it's no longer just dumping, right? We are seeing folks, we'll focus our remarks on our elders, but we're seeing folks, adults in every decade of their lives that are stranded at the hospital for any number of reasons. And so it's not just our elders, and it's not just because families are running off. So causes and contributors, there's a lot of them. I'm going to tap Diana in just a second. So the one is unrepresented patients and underrepresented patients. So these are patients who persistently lack decision-making capacity and don't have anyone who is able and willing to make decisions on their behalf. So not just someone who lacks a power of attorney for healthcare or a power of attorney, which wouldn't that be lovely if everyone had one of those, but even someone who is eligible to serve as a temporary healthcare surrogate. The state of Tennessee allows us to identify someone who meets criteria to serve as a temporary surrogate, but that person has to exist and be willing to serve, and that's not always the case. Or an underrepresented patient, someone who's willing but not always willing, or available but not always available. So under and unrepresented patients. Undocumented patients, right? Patients who are not eligible for health, for insurance. We can treat them, and we do treat them, and we will treat them to the very best of our ability while they're inpatient. That's not a problem. The problem is what happens when they're ready to go. if they now need services in order to live or in order to thrive or in order to be minimally safe that they're not eligible for, then they stay in the hospital until we can find some creative way of getting what needs to happen. Patients who don't have insurance, for obvious reasons, and here's one that was a surprise to me when I entered healthcare: patients who have money. Patients who have property. Who knew that would be a barrier? Who knew that would be a problem? But it can be. Patients like our Ruthie, who have memory problems but no real physical problems, are not eligible to go to a skilled nursing facility, or may not be eligible depending on what else is going on. Patients with mental health needs as well as behavioral needs, mental health needs as well as medical needs, especially if they have behaviors. Very, very difficult to find a safe place for them. Patients with a history of addiction. Very, very difficult to find a safe placement for them. And patients who have prior criminal convictions, particularly folks who have a past conviction of a sex offense. Very, very difficult to find a place that is safe and can meet their needs. So Diana, you could talk for about 4 hours on this, but what would you like to add?
First thing that comes to mind, anybody that's dealing with elderly people, one, everybody should have a friend that to try to at least have some type of a contact for them. And also, if you are helping elderly people, that they need to be encouraged to have someone else on their bank account, somebody that they trust, because if that person comes in the hospital, they're not represented, then it's very difficult to help them get where they need because we have to access their funding. So if they have advocacy in the community and somebody can kind of help them with that, I think that's very important, because those are things that can take a long time to help get them into placements when it is found. But as Annette said, all of these are challenging, and it takes time to be creative and to search. Just to kind of give some examples, we do have a handful of these patients currently at UT that we are working on. One patient, I can tell you that they had 300 skilled nursing facility referrals made on them, 300. That doesn't look good for that patient, because no matter where they go in the community, their referral's already out there. So that doesn't bode well. So placement for him has to go really outside the state. Last year, I didn't confirm my number, but I'm pretty sure we did 17 guardianship cases at UT. And that has been a steady incline since 2015, and that's just UT Medical Center. So I'm assuming the other hospitals are similar to us. That is a lot, and I think when I added those numbers up for last year, that's a 350 days. So 350 days over 17 patients, like Melissa had talked about, that we're not able to get other patients in the hospital.
So let's talk about consequences to patients, right? They are confined in a hospital room, usually to a bed, right? Usually to a bed, not even a chair. Sometimes they get up into a chair, but depending on what's going on with them and what's going on the floor, they may be in a bed all that time. So their mobility is going down. They're not getting great socialization because they are in a single person room. We're certainly giving them physical and occupational therapy, but they're not getting adequate they're getting hospital level, right? Which is acute care level. That's not rehab or skilled nursing level, PT and OT. So they're deconditioning we are watching them decondition as they are in a hospital. They're getting inconsistent caregivers. They're consistent in that it's the same set of nurses that are on the floor, but compared to where they might be for their new normal, right, it's inconsistent. It's a bunch of people they don't know, and they're floating in and out of their rooms compared to being at home or where they might be in long-term care. Despite our very best efforts, and those efforts are considerable, they are still exposed to infection at higher rates in the hospital than they would be at home. Again, despite considerable efforts to make sure that infection is kept at bay. They may be billed for a hospital stay that they didn't really need. What they needed was just a safe place to be. And depending on what else is going on, they may wind up losing their possessions. If they live in Section 8 housing and their homes are, or their apartments are marked as abandoned, then there is no choice but to have that place marked abandoned and their possessions have to be put out. And so everything that they had, now they've lost. If somehow we can get them to a rehab facility, now they have no place to go and their things are gone. So there certainly are consequences to hospitals, and I don't want to pretend they're not. I don't want to skip over this, but I really want us to think about what this is like for our people. This is where the real heartbreak is. But yes, of course, there are consequences to hospitals. There's, for one thing, just crude loss of revenue, right? Anyone that we could have served, that we're not able to serve, that's a loss of revenue. It's a loss of the ability to do what we do best, which is to cure people and get them on to their next phase when they're acutely ill or injured. We also frequently will not be reimbursed for patients if they don't require hospitalization. So yes, of course, there is that. I also want to touch on what it's like for staff. It's incredibly distressing to care for folks who are in this position because you see them. If you're a nurse, you're a physical therapist, you are a direct care provider. You're there to help people get better. Watching someone get worse, watching someone get increasingly lonely, increasingly sad, that feels terrible when you feel powerless to stop it. We call that moral distress. It's emotionally taxing, and it can strain professional relationships and interagency relationships because we're not always really aware of where the shortcomings are. So if only so-and-so would do their job. If only so, yeah, right? We all kind of turn on each other when and we all, in our heart of hearts, we know we're all doing our very best, but it's hard to remember that when you're watching someone who is suffering for lack of appropriate placement. There's one other thing. So, that was just it. It may sound a little bit crude to be talking about resources and money and so on, but we, especially for our smaller community hospitals, hospitals have to stay afloat in order to be able to serve their communities. And so you hate for it to make it sound like it's coming down to money, but money gives us the opportunity to serve our constituents. And that, as Melissa's talked about, turns out to be consequences for everybody. There are profound care delays. This was especially true during COVID. Profound care delays because beds are occupied by people who can't benefit from hospitalization. And so if you've waited for extended times in the ED, or if you've waited for extended times trying to get seen, sometimes there's just no beds because we have lots of our beds are taken up. With folks who have no place to go. I really debated whether that kind of cartoon was appropriate. We've got someone in a bed with two folks sitting by there. We're not your visitors, we're waiting for your bed. Little dark humor, right? Yes.
I just want to say, I had to take my daughter to the ER this past weekend, and we were there for over 7 hours, and we were in the hallway the whole time. So I can pretty much tell you what was going on with everybody around us. There was like no hint of privacy whatsoever. I knew every symptom this poor lady had and why she was there, and also the motorcycle wreck. I knew that he was, having his artery clamped. And I thought that was really concerning, just because, you don't necessarily want everybody looking at you if you're in the hallway, and then also you don't want everybody knowing what's going on with you if you're coming for something,
Exactly. We are really good at what we do. We are not set up to deal with that kind of overflow. And so yes, if the only thing that we can do is to have folks on stretchers in hallways, all kinds of bad sequelae happen, including a loss of privacy.
Well, even the mom was giving an IV in the hallway. I mean, and like, I didn't know what was going on with somebody in the waiting room. Like, oh, you're pregnant, you fell. I mean, I was like, this is mass chaos. And
Welcome.
yeah.
And again, this is hospital, and again, I feel like I don't actually have authorization to speak for every hospital, but I feel like every hospital would tell you the same thing. This is hospitals doing their very, very best, and it's real. The loss of privacy, the loss of confidentiality, it's real despite our very best efforts.
And it was uncomfortable. I mean, like you said, I'm sitting in a chair that was less comfortable than this for 7 hours with her. But they also had a homeless guy that they were like, you just have to go. And they said he comes all the time, you know, and they were basically like, hey, it's time to leave.
Yeah, and so, and like Melissa, oops, I'm sorry, guys. As Melissa was saying, social admissions, if it's someone who doesn't have a medical need, it may be that's not a care need that we can meet in the hospital. So that, and I saw a hand up over here.
Well, what do you do about the homeless population that comes in and does have a medical need, but then gets out of that medical need while at stay and discharged?
Yeah, so folks who are chronically unhoused, if they have a medical need when they come in, they are evaluated, they are admitted. But that is one of the categories of situations that make it very, very difficult because they still need a safe place to go. And if they,
But I would also say too, that once that person is cleared for discharge, if they come to us homeless, they will return homeless. Like, we don't have a magic wand to fix homelessness. And unfortunately, that does seem to be an expectation for a lot of people in the community. So we don't have anything to expedite that. So if they come to us homeless, they often leave homeless unless they have a resource or a medical need to be able to provide something like a short-term rehab facility. But even with that is a barrier even to the skilled nursing facilities.
So, like, if they have an amputation done or severe heart attack, stroke, paralysis, they tend to go back homeless.
Yeah, depending on what their situation is. I mean, we do our due diligence in trying to find whatever resources we can for them. Sometimes that ends up in a longer length of stay for some patients. But then ultimately, if we're not able to find some type of, rehab facility for them, I mean, we're not able to get them, an apartment, or we're not able to do those type of things.
Okay.
So something I just want to say, because Annette mentioned the moral distress. Do you know how hard it was for me to sit here and listen to what she just went through? Truly, I will take that back with me. I will not let that go. And that's what our staff, that's what they feel every single day. We don't like treating patients in hallways. I'm glad that getting an IV in the hallway was the only thing you saw. Truly.
Oh, we saw people going
Yeah.
to surgery that open wounds. I mean,
Absolutely.
My daughter has a vegus nerve issue to blood, so I was just like,
Yeah. So again, I said that we have gotten really good at lobby care and hallway care and hanging fluids in my office if it has to happen, all kinds of things, just because our beds, the ERs are overcrowded. And specifically working at UT, we know that ours is the worst based on a percentage of how many patients we serve compared to other local ERs. But it's not because other local ERs aren't going through the exact same thing. It's just a percentage of your overall annual volume is what it faces. But yeah, it was never a plan for it to turn into this, but it has turned into this.
Yes.
So, and I'm with the AAAD down in Chattanooga. So we recently had a call where a young man, homeless, 47, car accident, his leg got amputated. The hospital, he was telling us, discharged him, paid for him to be in a local hotel for 2 days, and then he's like running a fever again. He wasn't stable. I mean, the only thing we could recommend was to go back to the emergency room. And is that what you guys are? Okay.
Well, and before someone, we do our very best before someone is discharged back into either a shelter or, God forbid, to the streets. We try to make sure that they are able to manage themselves in that environment. And I'm going to look over, yeah. So often folks who might have gone home to be managed are going to stay with us longer because they can't get appropriate care. They can't provide their own appropriate care in that setting. But we're going to do our best not to let them go until we feel like they can manage. Yeah. Quick, and then we're going to have.
sorry, I have a lot of questions. But do the homeless people get a mocha score too?
If we're worried about cognitive impairment, we'll assess. Yeah.
Mental health included, then it seems like they would go to like some kind of mental health facility or intervention.
So.
Assuming they're full all the time.
Yeah, they are full frequently, and there's a list of criteria for mental health admissions just as much as there are for medical admissions. So it's not always that easy. And then we do have what we call our high utilizer patients, which could be what you saw when you talk about the patient that came in, that we discharge back out to the streets. Some of them make this choice. They have a choice. They have family. They have to choose to help themselves enough to get the rest of the benefits of not depending on the shelter or being homeless, that kind of situation. So those high utilizer patients, and one of the most common is chronic alcoholism. So we bring someone in and we have them for about 12 hours to make sure that they are medically okay and they have sobered up, and then we get to send them on their way and say, we will see you next week. But unfortunately, that is something that we deal with.
So if someone has a cognitive impairment, it may try, I've watched Diana so many times say, kind of look at a patient and say, well, they don't have this, they didn't come in with this resource, but maybe we can get them this resource. Maybe we can, right? So there are times when someone didn't qualify for something that they have come to qualify for while they're in the hospital. But you can qualify for something if the resource isn't there. The resource isn't there. So the fact that someone has a need doesn't mean that there is a resource out there to meet that need, and that is very, very common. So some of the obligations that not just hospitals. Hospitals are not equipped to deal with these problems. We desperately want to solve these problems, and we are not equipped. But some of our ethical obligations are collaboration and creative partnership with outside agencies. So I think we do a real good job of knowing who's out there and how we can partner. But I do wonder if the communication is as good as it could be, if we all are really aware of what's on offer and what is just not what an agency is just not equipped to do. I think we each expect miracles from the other, and I think knowing who does what and who doesn't do what is going to be very important. I think we all have to band together to advocate for legal and social change. Some of our laws are incredibly important, like EMTALA, we want that to stay, but some of the laws that we have need to be able to be modified so that there aren't legal and social barriers to what we then need to do. This next one goes with the immediately prior one. We also need to be thinking about what the unintended consequences of the change we're advocating for will be, because unintended consequences happen. And so rather than being afraid of those, we have to recognize there will be unintended consequences. Some of them will cause more problems than we had before. Trying to mitigate them before we get there, but then be ready to act quickly to change the unintended consequences that are going to happen. So we need to be aware of what could happen as we're trying to fix things. Two things that I want to talk a little bit more about too are we have to be very careful about the way we assess our patients' decision-making capacity, which I'm going to say a little bit about what exactly that means, and we need to make sure that we are appropriately balancing our duty to care with the dignity of risk. How many people are familiar with the notion of the dignity of risk? Some of you will be. So decision-making capacity, adults are presumed to have the ability to make their own decisions unless we have a reason to worry that maybe they're not. This is different from competence. Competence is a legal concept, it's decided in a court of law, but of course you can have legal competence, you can have all your rights and still not have the on-the-ground ability to make medical decisions. And so how do we decide if someone, and that is decided by a physician, by the way, the decision to not allow a person to make their own medical decisions and to turn instead to a surrogate is a decision, that decision is made by the treating physician. And so we look at 4 abilities. Can the person communicate a choice? That's the easiest one to assess. They don't have to be speaking the Queen's English. Maybe they can't talk at all, but they can write. Maybe they don't speak English, but we can use an interpreter. Can we somehow bridge whatever gap that might exist so that they can communicate a choice to us? That's number 1. Can they understand relevant information? Relevant information. I don't need, if you've got diabetes, I don't need you to explain to me what the islets of Langerhans are and what they do. That's not relevant. What I need to know is, do you understand what will happen if you do X, Y, or Z? Do you understand what the limits are? Do you understand what resources are or are not available? Do you understand enough about your medical condition to be able to manage that? So do you understand relevant information? Can you appreciate the consequences of a decision that you may be making? Do you have a set of values and goals and preferences that kind of animate the decision that you're making? Do you appreciate what will happen and what that's going to be like for you if you do X, Y, or Z? And can you reason? Can you use means to ends reasoning? Can you connect the dots? Can you connect the dots between current reality, what you're hoping for, and the decision you're making? So it's not, so notice that the MOCA is not on there, right? Notice that there's no numeric score that's going to tell you exactly. If you've got a very low MOCA, you're probably going to lack decision-making capacity, but maybe not. Maybe not. And even if you lack decision-making capacity, we still have to take your stated preferences seriously. So if someone lacks decision-making capacity, that doesn't mean we just get to do whatever we want with them. We still have to try to figure out what are their core values, what does matter most to them, and how can we do the things that are going to create the best environment, the best for them, not the one we want for them, but the one that they will flourish best in. So to have decision-making capacity, you have to have a set of preferences. You have to have an understanding of risks, and you need to be able to accept the risks to your values. So basically, you need to be able to make trade-offs. You need to be able to recognize that you can't have everything you want, and that this is more important than that to you. So this now comes on us, right? Autonomy and the dignity of risk. If you've ever had a healthcare ethics class, you probably remember the 4 key principles. I'm seeing some nods, thank you, people who've taken ethics. The 4 key principles, ethical principles in healthcare: autonomy, beneficence, non-maleficence, and justice. So autonomy, right? The obligation to respect the dignity of others, that's one of our core values. And dignity of risk is the idea that taking reasonable risks is part of having autonomy. Part of living the life of an adult person is being able to decide for yourself what's a reasonable risk, right? It's easy when folks are vulnerable to put that aside and to want to just, privilege safety over everything. But we want to recognize that overreach can actually cause more harm than good. And we've got to recognize that home is what counts as home, what feels like home, that is just a core part of who we are. It affects our daily life, it affects our identity, it affects our comfort. So we don't want to be too casual with what we're going to say can be someone's home. At the same time, balancing that is beneficence, the duty to care. So that's the obligation to look out for the well-being of other people, particularly those that have been entrusted in our care. And then non-maleficence, which is to do the duty to do no harm, and also to allow no harm. And I should say unnecessary harm. Harm is also unfortunately part of life. And so we also do have absolutely the responsibility to promote people's safety and prevent harm. So we can think of those as being in conflict, but I like to think of them as being a necessary tension, 2 sides to the very same coin. Because if we think about what puts people at risk, surely people can be at risk for falling, they can be at risk for inadequate nutrition, they can be at risk for taking their medications improperly, but they can also be at risk for loneliness, for isolation, for depression, for loss of socialization. So there's lots of other kinds of risks as well. So we might think about who benefits from making who benefits from making safety a top priority, right? We don't want to eliminate all risk. Okay, I take it back. I want to eliminate all risk, but we really don't. We want to manage and mitigate risk in a way that is appropriate and really does promote the flourishing of others. And so so what creative ways can we find that create a safe enough environment. And Diana, what you had said before about our folks who come to us homeless, it may not be as safe as we would like, but we're going to make sure it's safe enough before we release them out into the community. So if we're looking at a decision somebody is making, if they want to go into what we feel like is an unsafe environment, we want to kind of assess those risks in proportion. So how likely is the harm or injury we're worried about? How likely is it to happen? How bad is it? How detrimental would those harms or injuries be? How important is the desired activity or placement to the patient? Is it something that's Diana and I were just talking about our folks who absolutely do not want to go to a particular placement, but then sometimes once they're there, they find that they can adjust. And so how important is a particular plan? How feasible is the alternative? And how safe is the alternative? So we don't want to just automatically go to the one side of risk or safety. We want to assess these in proportion. So here are some of the things, this is not an exhaustive list, but here are some of the things that I think we can agree that we need, and I'm hoping will be a springboard for conversation. We need better coordination. We need better communication between all of us to make sure that we are using existing resources well. I think even with better communication and coordination, we need more post-acute options. I think we just plain do. I think we need, especially mental health and addiction treatment, both for folks who have physical medical needs and for folks who have only primarily mental health or addiction needs. We need more supportive housing so that we can age in place. And that includes memory care, including for our folks who don't have any other medical needs. Shout out to Lynette and Sandra for all the work you guys do. We want that wait time to be where it is in some ways because we don't want to place people prematurely and assign them a guardian before we can really look at, does this person lack decision-making capacity? Are they expected to in the future? And what would be best for them? So this is not a process we want to rush. Because it's basically what we're talking about is vesting someone's rights in another human being. We don't want to rush that. That's a big deal. At the same time, being in the hospital while that happens is not a great place for someplace to eddy. And so I wonder, this is more brainstorming than an actual call, I wonder if temporary guardians or a temporary guardianship program that can assist with just short-term placement that will then hand the baton off to someone else so that people don't get stuck someplace and we're not rushing what ought to be a very thorough, ought to be a very thorough process. I think we need more opportunities for all of our folks in the community to contribute to the community. What we've been talking about this whole time is where we are falling short in terms of serving others, and there's lots of gaps there, but we also, I think, have gaps in terms of creating space for others for them to contribute back to the community. There's something that we lose when we lose the ability to contribute, to work, to provide for other people. When you become a passive recipient of service, something in you dies. And so looking for ways that people can also contribute back, I think, is profoundly important. And it would help, I think, to have a community understanding of what the dignity of risk, so that we all are comfortable with what counts as safe enough. So we want to make sure that solutions aren't creating new problems. This, again, is not an exhaustive list, but just a few that that keep me up at night. I worry that patients could be placed while incapacitated and then lost to family that may be out there, but that despite our best efforts, we couldn't find, right? That worries me a lot. We work really hard to try to find family, but sometimes they're out there and we just couldn't find them. I worry that if we're not careful, I don't think this happens now, but I think if we move too quickly to try to place people, that someone's life savings could be depleted really quickly, and then they don't have options that they might have happened because they didn't have someone who knew them well and was able to advocate for them. We certainly can go overboard on safety and jeopardize dignity of risk, and can certainly go overboard on dignity of risk and allow people to live in danger. I do think these last two do happen. I think they do happen. So I'm hoping that we'll have some time. Do we have some time? We have 7 minutes. I'm hoping that we'll be able to talk a little bit about what we are seeing and what we are hoping for. Ladies, anything to add before I ask the, no? Okay. Folks, what kinds of things are on your minds about this topic, about what we've said? Yeah.
I just heard it kind of, one of my priorities for initiatives may be around loneliness and isolation, because it has so many detriments in regards to emotional health and physical health. So the fact that you mentioned it is kind of helpful. If anybody else wants to make a remark on that, I would really love anybody else's input on how big the problem is facing.
Yeah, what are we seeing out in the community in terms of the problems of loneliness and isolation? Seeing a lot of it. Yeah. Anybody want to say, yeah, please.
One thing that I seem to notice when I'm dealing with the clients that I work with is there seems to be, and I know that for like the social work, that's one aspect of the hospital situation, right? But it seems to me like there's just a lot of like compassion exhaustion out there with the staff and the nurses and the doctors and stuff. And when I have this one particular case that it's just beat me up, and she was actually at UT, and in her past, she was an alcoholic. But the moment that she was in, she was not. But she wasn't being heard by the doctors, she wasn't being heard by the nurses, we couldn't find anywhere, that we could help. She needed to be placed into a facility. We did start the choices application. That does take a minute. But she was literally released, like while she was in the hospital, she lost her home. It was known that she lost her home. But she was literally she was unable to walk. She couldn't hold anything. She couldn't feed herself. And she was put back on, just put back out. They knew that she didn't have a home to go back to. She didn't come in homeless.
Right.
They knew that she had lost her home while she was out there. She should have, in my opinion, but I don't work or do that job. In my opinion, she should have stayed there until, we know that choices takes forever, right? It takes forever to get them. But it was just mind-blowing to me. And the thing that just keeps ringing in my mind is how she just felt like nobody heard her. Nobody, heard anything that she had to say. And
I'm hearing a couple of things in a case, and obviously I don't know this particular patient.
Right.
I can't speak to
so
a patient like that. That patient.
The situation is for you, when you're looking around the staff and the doctors and the nurses and everything going on, at UT, and everybody is overworked, stressed beyond belief. Do you ever think, or do you guys do training with, these nurses and these doctors to try to remind them that these people are human, that they're not just numbers, that they're, because you see the human side. They see patients, documentation, numbers, get them in, get them out, fill the beds, all the things, and it seems to me that they put a lot of that on you. Obviously, that's your job, right? But
So I'm hearing a couple things. One is, as you say, compassion fatigue. Compassion fatigue is real.
Yeah.
It's certainly affecting everyone in healthcare. It's certainly affecting all of you. There is no way that you're not feeling it, and I know we're feeling it, and our staff are feeling it as well.
Yeah.
So what you're not going to hear me do is stand up here and say, "Oh no, we treat every single patient at every single moment with all of the compassion that they deserve." We're human too, and compassion fatigue is real. Another thing that I'll mention is that, and I know you guys have read about this, that turnover in healthcare is very, very quick. And so, and short staffing is an issue. And so while we're working a whole lot with staff wellness and trying to make sure that they're feeling, supported so that they can then bring that compassion to others, I will say it's difficult to try to, when folks are already short-staffed, to bring them away from the bedside for even longer to then work on wellness initiatives and education. It's challenging. We are working on it, but it's challenging
So that
for
is
sure.
part of like a yearly.
Yeah, it's more of a daily, it's daily, weekly, with every resource that we can find to kind of shore up compassion and wellness, we're using it. That in fact, at UT, we now have a wellness officer that's in charge of trying to make sure that our staff are well in the broad sense and able to then bring that compassion to the bedside. But that's real. The other thing that I'll say is that the patient that you're talking about, that really highlights the gaps that we mean. We can know that someone's about to lose their home, and there's nothing we can do, nothing that KCDC can do. It's like watching a wreck happen, and that sometimes there really are just gaps. And sometimes, how many of your case managers are new, Diana?
A lot.
A lot.
We have 34 case managers at UT Medical Center, and I would say probably maybe 8 to 10 of them have over 5 years of experience. And to be a very seasoned case manager, you need to be at least a year of experience. But we do have a lot of turnover because it's hard.
Yeah.
So all of the things that you guys have talked about, they're holding a caseload of 32 to 34. So when you take one of these patients that requires that much time, and then you're trying to pair it with someone who could be an easy, come in for a surgery, go to a skilled nursing facility placement, when you're spending that much time on this patient, or that patient sounds like a very big social issue, then you're taking time away from some of your other cases as well, and then you're trying to balance everybody's frustration. So it's very challenging.
Yeah, and so that coordination that we were talking about, I think there are probably more resources out there that just knowing where they are, who's appropriate for what, I mean, for sure. But then there's also just plain old gaps. I see that we are out of time. That's another scarce resource, right? You guys have been a great community, and I hope that we'll continue to talk about this.
If you have a CLE sheet that you need signed, please bring it to me and I'll sign it for you.
Okay, thanks everybody.